Okay, so I know you have finals and I saw your final outline and I highly recommend since I have videos posted for every single topic that you have for MedSurg on your final outline, including this one that will be uploaded today, to help those when to help use those when you're studying because I think it'll be really useful to have something that you can continually watch or something you can refer to if there was something you were confused on in, let's say, cardiac or respiratory or even neuro, and you need to touch up on things. So, yeah, I have everything there neuro, kidney, whatever you need. So, it will be there, it's going to stay there, and it should help. Um, but yeah, today we're going to talk about the patients with oral and esophageal disorders, and we're also going to talk about GI disorders, which is the main focus of chapters 40 and 41, which are on your final. So, basically, just for some quick anatomy, right? Our mouth is really important because that's how digestion begins, right? We need to chew that food so it can get to where it needs to be. And the more we're able to chew it, right, the stronger our muscles are in our mouth, the easier it will be to swallow that food and for it to be digested. But we have certain diseases or esophageal problems that affect our body's ability to masticate or chew, right, to communicate, or even just being able to swallow down food, right? And that can be also a serious respiratory problem. So, one of the more like common sort of diseases that you typically see affecting the mouth is called periodontal disease, where basically you start losing your teeth. And it could happen in like two different forms. We could have gingivitis, which is inflammation of the gums, or we could have periodontitis, which is where the tissue and that starts to really support the bone and teeth becomes inflamed. They usually go together when you have gingivitis or periodontitis, but it could eventually lead to tooth loss. You might also even see your gums recede when you have periorthodontal disease. So this can affect a lot of things because if you also have some sort of infection or disease of the mouth, you can have a respiratory infection. So that's why GI system is one of the most important systems because it is not just GI relating, it can affect everything. So who are at risk? What you're going to see these population of people who are at risk here be our at-risk population and our teaching points for the rest of MedSurg, right? You're going to see with GI, the teaching points, the education is just going to repeat, which should be very, very helpful when you're studying this system. So older adults, why? Because your muscles, right, they're not as strong as they were. So that could affect your mouth's ability to do what it needs to do. But in terms of, periodontal disease or gingivitis, right, you just have reduced immune system, right? Your tissues, your bones, all that starts to break down, and that could lead to some of these problems, right? If you're a smoker, that can cause tooth decay, and that can even, cause death to tissues. If you have a lower income or if you're less educated, that usually just means you might not have access to as many nutritious foods, which can affect your mouth. Or if you're less educated, you don't really know as much about what I should be putting into my body or what shouldn't be put into my body. So those are individuals that are at risk. And like I said, um, if you have a disease affecting the mouth, it could lead to cardiovascular diseases, diabetes, and even rheumatoid disorders. So sometimes the NCLEX and even nursing exams like to talk about dental plaques or caries. Okay, so basically a dental plaque is where we have tooth decay, okay? And sometimes we'll see patients need like, fillers or dentures and things of that sort. So how can we prevent, right, plaque? Well, wash your mouth with fluoride, okay? Have routine dental care. So think about it. If I'm worrying about something in the mouth, I should be telling them, hey, go to your dentist, right? Follow your every 6 months, like hygiene appointments, okay? Like make sure you floss, you brush your teeth, right? After you eat. Water with fluoride is very good for your teeth. It's because it has like a lot of minerals and that are actually really good for your teeth, better than regular bottled water. Um, Less sugar and starch, right? Because that can lead to tooth decay. Healthy snacks, and always brush your teeth after meals. And once again, it can lead to systemic problems. Oral cancer, right? So that is a cancer that we're getting in the mouth. And risk factors, which, like I said, are going to repeat a lot in the GI system, is tobacco use or smokers, right? Alcohol, infections like human papillomavirus, okay? Because that could be like mouth warts and that could lead to systemic infections and a whole bunch of problems. History with the cancer of the head and neck. Um, there's usually more incidence in men, and it can occur in any area, right? Your lips, your tongue, whatever, but usually see it on the floor of the mouth. Okay, this is very severe, right? Because if we're going to have cancer of the mouth, there might be surgeries needed, and the management could eventually affect your speech or, potential airway problems. So we always have to think about that. So, in the earlier stages, you might not really know what's going on. You might have signs of cancer that you will see that are just not only for oral, but cancers in general include painless sores or masses that don't heal. If a patient comes in and says, hey, I have this sore in my mouth, it's not going away, nothing I do is helping, they should go see, a specialist, okay? Um, we also have to be careful. There's a lot of bleeding or red and white patches. Those are early signs of oral cancer because that means there's an infection, things aren't healing, which means there's something going on in our immune system. Later manifestations, right, as it's getting worse, more, now there's going to be pain. Now they're going to have difficulty chewing, swallowing, or speaking. They might cough up blood, and they might have really enlarged neck lymph nodes or cervical lymph nodes. So if we're thinking about this as an oral cancer, right? If they do have that, right, we have to think, okay, they might have difficulties communicating. They might have difficulties with speech or swallowing. So they're going to have to follow up with their speech language pathologist. We need to see their history, right? The first thing that we always want to do on any question is if it says, what should the nurse do first? It should always be assessment. They should assess for something, right? So here they're going to assess, okay, right? Right? Are they having difficulty swallowing, talking, communicating, right? Do they have any history of oral problems or head and neck cancer? How is their dental and oral hygiene? Do they have a history of alcoholism or tobacco use? Okay. And how do they eat? We need to know all of this. We need to look in the mouth. We need to ask them about, are they having any sores and things like that. And the way that we could manage, oral cancer, which is usually like, radiation, chemotherapy, or surgeries, especially if it's in the tongue, they might have to do surgical removal of the tongue or a part of the tongue, which could impair speech forever. That's the risk with these potential surgeries. So, like I said, we're talking about oral. So if we're thinking mouth, we're like, what should we do? Right? It's the mouth. Well, right? Mouth care, always having dental care, gentle brushing or flossing because they have sores and bleeding and we don't want to make it worse. We don't want to use mouthwashes that have alcohol in them. So that's a teaching point, right? Because that's going to hurt them. Oral hygiene. That's going to be the main thing that you're going to be teaching them, right? If they have a dry mouth, they could drink water or sugarless lozenges. Sugarless because, they could have the tooth decay, or they could get like saliva stimulants like Saligen to help produce saliva. Remember, they might have difficulty swallowing, and or if let's just say they have a surgery of the tongue and that removes, that could reduce salivation, and we need to salivate to help get our food down. So that's really, really important. Another thing, right? We have to make sure they have good food and fluid intake. So they need to speak with a dietitian. They need to speak with a speech language pathologist. Why? Because if they have trouble like swallowing, they will determine the extent and what types of food they can eat and drink safely. So we also need to always take into account their culture and social preferences when we're considering a plan of care for this patient. And most importantly, right, a positive self-image. Some of these patients might lose the ability to speak, right? And that could be very, very hard to adjust to, right? You've been speaking your whole life if you have the privilege to do that, and now you can't do that anymore, or other changes, maybe from surgeries and whatnot. So we really need to offer acceptance, support, and even refer them to support groups if we need to. We want to minimize pain, right? Because remember, they might have a lot of bleeding, oral sores, and things like that. So no spicy or hard foods, rough foods is going to hurt them. Oral care, you're going to keep emphasizing that. The oral care is really going to help with everything. We also want to prevent infections, so they should always clean their mouth, if they have any, open sores, be careful and mindful of that and things like that. Um, so this is just some disorders of the esophagus. There's a lot of them, but one of the more important ones, or one of the ones that comes up the most, is GERD, or gastroesophageal reflux disorder. Now, with GERD, what happens is that we have two little sphincters, right? So we have one um, right, like, behind the mouth when you're about to enter into the esophagus to prevent, right, food or something unnecessary from getting down there. We have, like, protective sphincters, and then we have one at the bottom near our stomach to let food in there. What happens is that that lower sphincter that covers the stomach opens a little bit. So we get acid and that backflow of that gastric stomach content into the esophagus, which is really, really painful. Okay, so where do we see this? Someone who has older age, if they have irritable bowel syndrome, obstructive airway disorders, um, but really, really important risk factors that we see with someone who has GERD, which is going to come up every single time for all of the GI disorders. So I would like memorize this is tobacco use, coffee drinking, alcohol consumption, and H. pylori or Helicobacter pylori. It's a type of bacteria that can cause GERD. As I said, anyone who just joined, please put your SFCID number into the chat for me. Thank you. But anyway, so yeah, like I said, GERD causes reflux, right? It causes some of that heartburn, that pain feeling because that lower sphincter is open. And these are the common risk factors. So I would note tobacco use, coffee drinking, alcohol consumption, and H. pylori. So, how do we manage this, right? Well, if the lower sphincter is open, right, it's going to cause a lot of heartburn, especially after you eat. Because when you eat, that's when it opens even more so that the food can come down from the esophagus. So, what should we do? We should have a low fat diet. That's going to be really beneficial for this patient. Avoiding caffeine, tobacco, beer, milk, any foods that contain peppermint or spearmint, carbonated beverages, that's all going to be really, really hard in that esophagus. And a issue that we have with GERD is that esophagus, right? If that sphincter is open and gastric acid is acidic, it's meant to only be in the stomach. If it leaves and it comes into the esophagus where it's not supposed to be, they have risk for ulcerations. So, if they're at risk for ulcers, right, all of this stuff would further agitate it too. So, we really have to watch out for that and think about ulcers. Just keep that in mind when I continue to talk. Avoiding spicy foods, right? That would irritate an ulcer, or just gastric acid, it would make it more acidic. Um, Eating or drinking 2 hours before bedtime, no. And one of the most important teaching points is sitting up when they eat and staying up, head of the bed elevated at least 30 degrees while they're eating. That's going to promote it to go down, and it's going to prevent that gastric from coming up, right? Because imagine if you lay down, right, and you go all the way back, and that sphincter is open, it's going to kind of come up. It's going to like roll up with gravity. But if you are sitting down and you're sitting up after you eat and let your body digest it, you're not going to have as much gastric acid come up. Now, I would highly recommend going over your GI drugs, because I know I was tested on different GI drugs in relation to management. And every single one that's going to come up is those PPIs, those proton pump inhibitors, right? Because they reduce acidity, right? Those ones that end in prozole, right? antacids, right? Antihistamines, things like that. So please definitely go back to your GI medications and review them because they become very important here and they could be, they're fair game to be asked on your exam. Okay. So another thing that I want to point out here that I didn't get to mention about the ulcers, right, is that NSAIDs increase ulcerations. So we're going to also teach them that for pain management, they're not going to take NSAIDs. They're not going to take their ibuprofen. They're not going to take those, okay? They could take Tylenol, but they cannot take NSAIDs because NSAIDs are going to hurt that lining and could create ulcerations, and they're already at risk for ulcerations. Okay, so another really, really common GI not as necessarily a disorder, but something that we do is enteral nutrition. Now, enteral usually means that you're going into the stomach to give them food, okay? So this is how they're going to be getting it, right? This might be a patient who's comatose or, they can't tolerate foods on their own, so they have to get nutrition somehow, and this is how they get it, okay? So what are advantages of this? Well, it's safe. It's cost effective. Okay. It keeps the GI tract moving because we're getting food to go into the GI, right? And it helps maintain all of those normal functions of metabolism in the body. Okay. But it helps meet those nutritional requirements that we just need to function. Now, always before you do a tube feeding or anything, you must be able to confirm placement. Okay, so before you start, you need to make sure you confirm placement. Now, sometimes they might do that with, an X-ray. Sometimes they might do something where they do residual removal. So let's just say, for example, they put in, sometimes they call it a peg tube, right? It's in the stomach, and you're trying to figure out, hey, are they actually getting their food? So if you open the little peg tube, there's like a little cap at the top, and you put in like a syringe, an empty one, and you pull back a little bit. If nothing really comes out after, let's just say, 2 to 3 hours, enough time to digest the food, that's really good because that means that they're digesting it and it's not sitting in the stomach. But if you pull it back and it's filling up a 10 cc syringe or whatever, that means they're not tolerating it, that there's something wrong with this tube, okay? Another thing, right? We have a tube, we have an open hole in the stomach. We have to watch out for infection. Okay, so we need to really watch out that we still need to give them oral care because even though they're not getting anything in them by mouth, they're at risk for infections and things like that. Okay, and we must educate them, right? If in the family, what's going on, why they're getting this. I think I just moved these two. Oh, I don't know. Sorry. Okay. Anyway, so yeah, like I said, tube placement, ability to tolerate the formula. We already talked about that residual volume. See where it says right here, check gastric residual volume. That's what I'm talking about, right? Signs of dehydration, right? Looking at those vital signs, okay? And things like that. We need to see what's going on, right? Their sugar levels, right? They should be going up when they eat, right? Or the food coming into the stomach. Anything like that. Okay, we need to see if they're having edema. If is it not going into the stomach, and then the food or that internal nutrition is going somewhere else, and signs of infection. Okay, so if this is a GI disorder and we're talking about, we want to see if they're getting their food. We want to look at daily weights, right? Make sure they're not gaining any like edema in the next 3 days. I&Os, and always consultations with the dietitian. Once again, just for like maintaining this feed, right? Because we call it a feed, right? So it's prescribed at a usual 4 to 6 hour rate. Usually what you'll do is you'll put water into it or like to sort of clean the tubing, and then will attach the feed. The feed will come down after. And usually you do 4 to 6 hours, and then after that, you usually change the tubing and change the system to prevent infections. Because remember, this feeding is sugary, and bacteria love sugar. So if we keep using the same tubing, that's at risk for infection, and do not mix medications with the feedings. That can go very wrong. So remember, some medications could also affect your GI, and they might not be tolerated well, medications and feedings. So you should always hold your feedings when you're giving a medication. So, other things, right? Make sure they're going to the bathroom, right? A part of this whole enteral nutrition or getting that outside nutrients is making sure they can go to the bathroom. Okay, they need to be hydrated, so we need to make sure they're getting, if they're not conscious, making sure they're getting fluids via IV, and making sure we give them support. Now, I just want to also show you a gasostomy or a jujuostomy. So basically, this is like another sort of hole that we put into the patient. And once again, if it's a hole, skincare, right? Infections, right? How are they getting their nutrition? Things like that, okay? So I want to show you a picture because there was not one before as an example of one. So basically, it connects to a part of the small intestine or stomach. Okay, and this is how we could also get fluids or other things that we need in. But what do we got to watch out for? Infections. If there's blood coming in, they might be bleeding, right? Is it being clogged, right? Is the feeds and whatever we're putting into that tube, is it being able to get through? Things like that. Um, Okay, so once again, right, we got to prevent infections, maintain skin integrity, right? Because it might rub, right? So we might need to put like skin barrier moisture onto it and things like that. Um, right? They might have, a little self-conscious about having a tube. Some people have these, gasostomies or these things for life. So we have to be really careful and like help them and give them support. Other things, right? Once again, always nutritional needs, always preventing infection, enhancing body image, monitoring for complications. All of these are just going to repeat for everything. Now, let's just say we have a patient who has like an esophageal disorder, but it's like not cancerous, right? We're thinking about the esophagus where it's near, where we breathe. If it's an emergency, they might not be able to breathe. If it's not emergency, right, we'll be able to look at their history, we'll get a nutritional status, see where pain is, things like that. But we need to consider what's going on, right? If the question said that, a patient has a history of like muscular dystrophy, right, and they have difficulty swallowing and things like that, and they're coming in and gasping for air, that would be an emergency, okay? So we need to evaluate what's going on with the patient. But if it's, not an emergency, it's not cancerous, right? We want to have adequate nutrient intake, right? We need to avoid respiratory compromise. We're talking about the esophagus, so we have to be careful with respiratory problems and even aspiration, okay? That's always a risk. Pain and making sure they understand what's going on. Nursing interventions, once again, relieving pain, education, aspiration, right? You're always at risk for aspirating, so we need to be careful with that, and encouraging adequate nutritional intake. It's just going to repeat. Is there any questions? No? Okay. So the next thing we have is management of patients with gastric or duodenal disorders. So we have something called gastritis. Now, anything that ends in itis means inflammation. So even if I can't remember, like, hey, I don't really know what this is, I know gastro or gastric means something to do with the stomach. And I know that itis means inflammation. So there's some sort of inflammation in the stomach. So acute means it's temporary, okay? So we're going to have rapid onset of symptoms. Um, we're going to have problems with, taking in food. It might be, a little inflamed, it might hurt, things like that, okay? So causes of why someone might have this sort of inflammation might be alcohol, medications, different things. But let's just say this inflammation is caused by prolonged exposure to something, right? And now it's not going to go away. Now they might have ulcers. Now they might have an H. pylori infection, which could also cause ulcers. Um, And this is a more serious problem, and we're talking about more long-term care. And think about it, right? If someone comes in, and maybe let's just say it is caused by an infection, right? A bacterial infection, right? It's acute, it's rapid onset, right? We see symptoms very quickly. But if they don't treat it, right? They don't treat some sort of bacterial infection that they have, it can get worse and turn into chronic. So anytime someone comes in, we need to do things immediately. And remember, this is just inflammation of the stomach. So it's going to be a little painful and it's going to be hard, to get some things down in the stomach. Because imagine you're eating, but your stomach's inflamed. It's going to hurt. So this is like how it looks a little bit. You can kind of see that redness in the like gastric area. And I just wanted to, it was in your slides, but I just wanted to keep it there because I thought it was a good visual of what's going on. So what happens, right? If the manifestations in acute are epigastric pain or like pain in that like throatish area, dyspepsia, which is basically like a hard time drinking and getting things down. You might have nausea, vomiting, anorexia. They might even have hematemesis, which means you vomit blood. Chronic, we're thinking about, right, they've had this for a really, really long time. So they might have fatigue, they might belch, might have a sour taste in their mouth, they might have halitosis, which means bad breath. Also nausea and vomiting, but because this is chronic inflammation of the stomach, we also have risk of anemia, percutaneous anemia, which is basically malabsorption of a vitamin B12. So it can cause absorption issues. Okay. It could even be asymptomatic chronic. So that's why we always need to do good assessments. And how would we see if they have gastritis? Well, we can do an endoscopy, or we can get like a tissue sample by a biopsy. So how are we going to help someone? We always said tobacco use, alcohol, all of these problems, foods that are spicy and unpleasant could affect any sort of stomach issue. So they should refrain from alcohol or foods until the symptoms subside. Remember, if this is acute, it's only temporary. So if they're going to eat food, that's going to hurt their stomach even more. So we're going to try to get them away from food right now. And how can we help them? Give them IV fluids, right? Antacids, right, to reduce some of that inflammation and acidity, okay? Proton pump inhibitors, antihistamines, right, for the acidity, but also for inflammation, okay? So we're giving all of these different things to help with that, okay? Chronic, right, we might need to modify diet. This is long-term, so a lot of foods might hurt the stomach, so we need to do more long-term interventions, reducing stress, still avoiding alcohol, and NSAIDs. Remember, NSAIDs are not recommended in a GI issue because they cause ulceration. So if that's an answer, it says, oh, what should I teach my patient? And it's related to a GI disorder, I would pick the one that says, tell them to not use, NSAIDs. So remember, this is also inflammation of the stomach. They might have a hard time taking in foods and fluids. So we want to make sure we get them good nutrition, reduce any anxiety that they're having over the situation. No more alcohol, cigarette smoking, caffeinated beverages. That's all going to hurt, okay? Keeping up with that speech language pathologist to make sure when they could start getting solid foods and liquids, because remember, they're the ones that can determine the swallowing ability. We cannot do that. Promote fluid balance, right? Monitor INOs, look for signs of dehydration. All of these GI disorders, you have risk for dehydration. So you need to look for those signs, right? Are they having electrolyte imbalances? Is their skin turgor not so good? Are they having a prolonged capillary refill? Are they hypotensive and have compensatory tachycardia? Okay, those are the things. And also measures to relieve pain, but not NSAIDs, Tylenol. Okay, now peptic ulcer disease can also be caused from GERD. So if you have GERD, right, and you get those ulcerations, you could get peptic ulcer disease, especially if the GERD is caused by H. pylori. So all of these like systems and disorders can be intertwined. So peptic ulcer disease means there's an erosion of the mucous membrane that lines your gastric tract, okay? And it's usually associated with H. pylori. It could also be associated with a history of smoking and alcohol use, okay? So Risk factors also include, right, too much secretion of stomach acid, because that stomach acid is the cause of the ulcers, right? Because acidity is not supposed to leave the stomach. If it goes somewhere else, it can cause ulcerations. Dietary factors, spicy foods, right? Chronic use of NSAIDs. All of this stuff is just going to keep repeating. So if I were you and I was studying, I would write my common risk factors on the side for all of these GI disorders. Now, manifestations include like a gnawing pain, a little burning, and like the mid epigastrium, heartburn, vomiting, right? All of these are going to cause heartburn because of that acidity that's coming into this area, okay? Now, like I said, you got to go back and look at your medications. If it's caused by H. pylori, we need to get them on antibiotics and teach them about that, right? How do we use antibiotics properly? Lifestyle changes, right? No more smoking, no more drinking, avoiding spicy foods, things like that, right? And maybe possible surgery. Now, this is just a picture of what it can look like as it gets worse in that sort of stomach area. But if we're thinking about, patient has gastritis, peptic ulcer disease, whatever, GERD, right? A lot of these assessment findings are going to be similar, right? Let's look at their history and their presenting signs, right? Do they have anything that's indicating pain, right? Are they showing, they might have ulcerations, they're having a lot of heartburn, right? And it's hard to tolerate food when they're eating, right? Because it hurts so much when they're eating. Look at their history, look at their dietary patterns. A really important question that they might ask is like, what should you do on a select allowed apply? And one of them is keeping a 72-hour diet diary so that we as the nurse can say, hey, you know what? We're noticing that they're eating a lot of fried, spicy foods, not good, right? Abdominal assessment, right? Let's go and listen to the stomach. Let's see what's going on, right? Palpating it. Vital signs, okay? Are they using NSAIDs chronically? Do they have any signs of anemia or bleeding? Okay, this is what we want to be looking at. Now, what are some major goals, right? Nutritional requirements, making sure they get the food that they need, reducing anxiety, related to the situation that they're dealing with, relief of pain, because it's going to be very painful, and absence of complications. This is just going to repeat over and over. Also, watching out for potential hemorrhage, proliferation, and make sure they understand what's going on, because education and really getting the idea that this is what's going on, that they're having ulcerations in their stomach, they need to know why they need to stop these dietary or medications or whatever is the cause. Is there any question? No. Okay, just stop me if you have a question. So the last thing we're going to talk about is patients with intestinal or rectal disorders. So we were talking about like gastrostomy or jujuostomy. So these are parts of the small intestine. We have duodenum, jejunum, and ileum. And it goes in that order, right? So duodenum's first, then you go into the jejunum, and then we go into the ileum. So this is how our small intestine works, right? And the most important thing about the small intestine is that it absorbs all of our nutrients, right? The goal is to help with absorption. So that's going to become really important. A lot of problems that we're going to see is malabsorption related to if there's an issue with the small intestine. And with the large intestine, we're talking about the colon, right? Where all of that food and all of that time was now, converted into a harder form and comes out as stool. So, one of the most common problems that maybe some of you have experienced or know someone who has experienced is constipation, okay? Especially in our older population. This means that they're not having 3 bowel movements a week. And they're usually hard and dry, and it's really, really hard to go to the bathroom. Medications can cause constipation, right? An example is those narcotics. Chronic laxative use, even though you can take laxatives to help relieve constipation, it can cause constipation. So laxative use, we don't really recommend it, right? If they have weakness in that sort of tract, If they have increased intra-abdominal pressure, how is their diet, right? Is it not high in fiber, right? Are they eating a lot of milk and dairy products? Does that can bind you? If you don't go to the bathroom when you need to go to the bathroom, right, and you feel like you gotta poop and you don't go, that can be a cause of constipation as well as lack of regular exercise. So the three rules of thumb that you can never forget when it comes to constipation is increase fluid, increase fiber, and increase exercise. Those are the three main teaching points. So this is usually perceived because remember, the patient knows when they're not going to the bathroom. This is not something that we can necessarily like see. It's usually somebody coming in saying, hey, I'm recognizing this problem. So we already talked about some of those manifestations, right? Fewer than 3 bowel movements a week, abdominal distension because everything's building up, pain, being bloated, you have a sensation that you're not really going to the bathroom fully. You strain to go to the bathroom. And when you do, it's small, hard, dry stools. So, assessment findings, right? Chronic constipation mean we don't really know. It's idiopathic, meaning we don't really know why it happens. We need to go for testing to understand why they're having that severe constipation, but we need to get a good physical and history so that we can understand what might be the cause of their constipation, right? Is it their diet, right? Is it not enough exercise? Things like that. We can give them a barium enema to help them go to the bathroom. We could do a sigmoidoscopy where we can look at the sigmoid to see what's going on, and stool testing to let us know if there's anything going on, okay? So, what are some problems? Well, imagine if you're constipated, that means stool is building up in that colon, which means there might be problems, right? It might build up so much, there might be a lot of pressure in the colon, which can lead to decreased cardiac output because there's a lot of pressure on those tissues. Fecal impaction, where it's just like all the stool. It's kind of like imagine um you cleaned your room really quickly and you shoved everything into your closet and you're pushing the door shut, like you're really, really trying to close it, and then eventually you do, but you struggled a lot. That's kind of like fecal impact, and so much is building up there that it could be really, really hard to get it out, and then it's really hard to keep it in. And sometimes they might have like occasional leaks because of that. Hemorrhoids, fissures, rectal prolapse, which means that the rectum actually turns inside out, can be a complication of constipation, and a megacolon, which is like more swelling. So, what should we tell them, right? Hey, here's how a normal bowel pattern should work. They should increase their fluid and dietary fiber. They should exercise and be very active regularly, but avoid laxative use unless super necessary. Diarrhea, another complication that we see very commonly in the GI, right? So we have a lot of bowel movements, more than let's just say 3 in a day. I see a question. No, nobody has a question? Oh, maybe that was just the system. Okay, well, if you do, just ask me. Um, do you have a question?
Yeah, I was asking, how long does it take for complications to occur when a person is constipated?
Normally, it's mostly acute. So hopefully there shouldn't be, but honestly, this is probably someone who has like chronic constipation who's probably had it for multiple months. I would say like decreased cardiac output, and the other ones would take much longer to come. But I would say you could definitely see some of these problems happening with like 4 months. If it's like really, really bad and they're not going because the blood flow is going to decrease, right? The poop is building up in this area and it can just cause a lot of complications. It can cause the rectum to even, start to tear and have some fissures because nothing's coming out. So I would definitely say it would be more of a couple of months, but I think the older you get, the more quicker these complications can show up.
So it's more chronic than acute.
Yeah, so the complications wouldn't be I've been constipated before. I didn't have like, any of those problems, but like for this is for more or less someone who has chronic constipation. And if that is, those are the complications they will see. And usually chronic means at least 3 months or more.
Yeah, I was just trying to make sure. Thank you.
You're welcome. But yeah, so that's it for constipation. Now we have diarrhea, right? Which is the complete opposite of not being able to go to the bathroom, where you have so many bowel movements in a day, maybe three or more. And the consistency can change, okay? But it's usually more on the liquidy side. So there's a lot of pain, right? A lot of need to go. It can be acute, persistent, or chronic. What are some causes of diarrhea? Well, I know if you have like the norovirus or a GI bug, you can get diarrhea. Medications can cause diarrhea. Tube feedings, especially when you first start those enteral feedings, they can have diarrhea because it's new. Metabolic or endocrine disorders and other things, okay? So it can be caused by a lot of things, but one of the most common is infection. So what are manifestations? We already talked about that, right? Increased frequencies, the stool consistency changes with normally liquidy, abdominal cramps, distension, borgo, I don't know how to say that word, but this one right here means that they have rumbling or gargling noises made by the stomach and GI tract. We have anorexia and thirst, right? Because they're just going to the bathroom so much and not really being able to absorb anything in their GI tract, right? It might be painful. And they might have something called tesemus, which is a persistent and painful desire to evacuate. So it's going to hurt really bad. So complications, right? We're having diarrhea. We're not able to absorb things. It's just going through you really quick. So fluid and electrolyte imbalances, dehydration, cardiac dysrhythmias, right? Because that dehydration could lead to more problems and cause cardiac arrhythmias, especially if there's fluid and electrolyte imbalances, right? If low potassium, that can cause a cardiac dysrhythmia. Now, chronic diarrhea can cause skincare issues, right? Because let's just say this is a person who has chronic diarrhea and is incontinent and they go a lot, right? And like poop and pee, all that stuff is not supposed to like stay on your skin because it's irritating and it can cause skin breakdown. So if you have chronic diarrhea, right, that could actually affect the rectum and skin area and cause some skin breakdown and irritation. So, what should we tell them? Hey, like if you're going to the bathroom, you tried taking a medication, didn't work, you need to know when to come to the doctor, okay? If it's nothing's working and you can't stop this diarrhea, you need to come in immediately because you can be dehydrated and you can go into shock. You need to rest, you need to keep very high intakes of fluid. Avoid any irritating food, so no carbonated, very hot, very cold beverages, just something light, plain, bland food. Um, Perianal skincare, okay, make sure everything's clean. Medications, avoid milk, fat, whole grains, fresh fruit, um, because that can also irritate it more. We really just want them to eat like crackers, something really bland. And remember, if they're lactose intolerant, they need that can cause diarrhea. So that's like our dairy products. So another GI problem is that we have fecal incontinence, which means that we keep going to the bathroom. And that just usually means that we have sphincters everywhere, but we have an anal sphincter, which is like blocking that in between, like, defecating it and keeping it in. It becomes very weak. So that sphincter can't really do what it needs to do. The same way in GERD, that lower esophageal sphincter became a little loose, let's just say, or open. You start letting things out. And there could be lots of causes. It could be traumatic, non-traumatic, a neural problem, like let's just say diabetes. It can be caused due to inflammation. There's a lot of different reasons as to why they could just keep going, right? Diarrhea, if they have fecal impaction, like I said, sometimes they could just try to spurt out a little bit. So it can cause a little bit of like diarrhea or just poop to come out and things like that. So, usually with fecal incontinence, you get some soiling, maybe in your like undergarments, occasional urgencies that you really need to go. You have a loss of control because you can't hold it in. And even though you might not be able to hold it all in, you also don't feel like you let it all out sometimes. So you have to be careful with that. And sometimes it can be so bad where they just go all the time, and it's really hard to control. So, how can we assess this? Well, we can determine why are they having fecal incontinence, right? Is there something wrong? Is it traumatic? Is it neuropathic? Is it an inflammation process? What is it? Look at the rectum, get an endoscopy, get a barium enema to help get rid of some of that to see what's going on. Okay. Um, and the help with fecal incontinence, because you keep going so much, is support, right? Because they might feel, right? They might not have, self-esteem problems because they keep going a lot. They might not want to go around people because of that. Skincare, because going so much can cause irritation. And bowel training. They usually have different sorts of movements. I think one of them, I'm not 100% sure, is called Kegel exercises, which help so that you don't really go to the bathroom as much. It tries to help train your muscles to hold it in a little more. But, it still is hard to keep it in, but these are some of the things that we could do. Now, irritable bowel syndrome is a chronic disorder where you can have diarrhea, constipation, or both. Your GI system is very confused almost all the time, okay? What can trigger it? Stress, sleep deprivation, surgery, infections, diverticulitis, and even some foods. Okay, and these will be our teaching points, right? If this is some of the triggers, we need to teach them, hey, what are your triggers? How to avoid those triggers so that way they have less of these symptoms because it can be very, very painful. And when you have the alterations in bowel patterns, right, some days you might be vomiting and then having massive diarrhea. Some days you're constipated, but it's very, very painful. You also have pain, bloating, and abdominal distension. So, how do we look at this? Well, we look at stool studies. We could do a proctoscopy, which is looking at the rectum and anus, a barium enema to kind of see, pull out some of those things to see what's going on, and a manometry, which means it detects patterns of muscle activity in that rectum area. Now, oh, sorry, I skipped one. So what do we teach them? Like I said, to avoid triggers, to keep a food diary so we know if there's anything that's related to the food, implement any diet changes if it is related to food, make sure they have good fluid intake, avoid alcohol and smoking, that's for everything, and relaxation techniques, especially if the trigger is due to stress. Now, we also said, right, thinking about the small intestines, we can have problems with malabsorption, right? The ability to absorb our nutrients. So they could be transport or mucosal disorders, infectious diseases, postoperative malabsorption, things like that. Or even anemia, right? Percutaneous anemia means that there's a malabsorption of vitamin B12, right? So there's disorders like that. So, what do we look? Oh my God, sorry, I keep skipping. I don't know why it does that. But the manifestations of malabsorption include frequent loose, bulky, foul-smelling stools that are usually gray and have a really, really high fat content. Um, the symptoms are very similar to irritable bowel syndrome, and they also have a weight loss and a vitamin and mineral deficiency. But definitely that high fat content and that grayish discoloration is going to be a key for the malabsorption because, right, how does stool get its color? From all the things that we're able to let go, right? All of the vitamins that we have, right? But if we're not really absorbing anything, it's going to affect the color of the stool. So, what do we want to look at? Fat analysis, right? Because it has a high fat content. We know they're having a malabsorption problem if the fat content is high. Lactose tolerance test, right? Because people who are lactose intolerant can't really digest the dairy products, okay? We could do dilose absorption test, which means that we check how well the intestines absorb simple sugars. We could do Schilling's test to see how well they absorb vitamin B12. And we could do a bunch of other things, okay? Now, what do we do if they have malabsorption? Well, we need to still figure out a way to give them those nutrients. So, vitamin replacement, dietary therapy, probiotics, which promote GI health, um, potential fluid and electrolyte imbalances, and we need to watch out for those, right? And if they have malabsorption, if we can't get those calcium and vitamin D, they're at risk for osteoporosis, okay? So, those are things that we need to keep in mind. Now, one of the other few diseases that I actually we is really important is celiac disease. This is a disease of malabsorption. It's autoimmune, and you cannot absorb gluten. And gluten's in a lot of things like wheat, barley, rye, grains, malt, dextrin, brewer's yeast. It's in everything almost. And here's the problem with this is if you have celiac disease, you have an intolerance to gluten, and the gluten, if you do eat it, it can eat away your intestines. I actually had a friend who has celiac disease growing up when I was little. And when she was told that, she had a lot of abdominal pain. And I learned from her that when you have celiac disease, one of the things that you need to do is that they cannot cook food in the same pots and pans that gluten foods hold. So they need to have their own utensils. They need to be washed separately. They cannot have any foods that contain gluten. Okay. So it's very, very serious. They have to check the packaging of everything to know if they can consume it or not. And if it doesn't say gluten-free or non-gluten-free, they don't eat it. So, what are some manifestations? Diarrhea. I don't know how to say this one, but that just means fat and stool. Um, so other things that they have is abdominal pain, abdominal distension, gas or flatulence, and weight loss. Okay. Um, so like I said, they cannot eat gluten foods, so they need to speak with a dietitian. There's nothing you can do to cure this. There's no medications to treat this. Like I said, patient teaching is, hey, do not cook your foods on pans that had gluten in it. They need to be washed separately. You need to have your own things, and you need to watch out for food labels. Check if they say gluten-free or if they contain gluten. The last thing I want to talk about is appendicitis. It's one of the most common abdominal issues, and it can be emergency. And you commonly see this in children. What happens is that appendix, which is in your right lower quadrant of the stomach, becomes inflamed and edematous, and we have a big issue, okay? That inflammation causes pressure, which causes pain. Now, I want you to know these manifestations, right? Right lower quadrant pain, positive McBurney sign, pain upon palpation of the right lower quadrant. If they have pain there, expect appendicitis, anorexia, nausea. And here's the thing, if they have a sudden relief of pain, let's just say they came in screaming, oh my God, I have so much pain. Like, you need to help me, like, whatever. Their vital signs are crazy. Then all of them, they say, Doc, you know what? I feel better. Their appendix might have ruptured and you need to notify the provider. That's one of those NCLEX questions where you pick notify the provider because this is a medical emergency. So, what are our goals though overall? If it didn't rupture, it's not an emergency. We want to relieve pain, prevent fluid volume deficit, reduce anxiety, right? Especially because they're having a lot of pain, that's going to cause anxiety. If they have a surgery, watch out for surgical infection at the site, prevent atelectasis or, collapsed lung. So anytime you have a surgery, you always have to watch out if something can cause trouble to the lungs, right? Maintain skin integrity and make sure they have good nutrition.